Hello and welcome to today's webinar, Words Matter, How Language Used in the Healthcare Setting Can Impact the Quality of Pediatric Care, made possible by the Robert Wood Johnson Foundation. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, audio lines are muted during today's event. There will be a moderated question and answer session during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. A brief online evaluation will pop up on your screen following today's event. Your feedback is very important to us, and we hope that you'll take a moment to complete this survey. We'll now turn the webinar over to Armel Cazo, Senior Program Officer at the Center for Healthcare Strategies.
Thank you so much, Travis, and good afternoon, everyone, and welcome to today's webinar, Words Matter, How Language Used in Healthcare System Settings Can Impact the Quality of Pediatric Care, made possible by the Robert Wood Johnson Foundation. So my name is Armel Cazo from the Center for Healthcare Strategies, and I'm honored to be here today alongside our amazing presenters, our CHCS colleagues, and all of you. We want to express our heartfelt gratitude to each of you for joining us on today's webinar. So this slide shares a little bit about the Center for Healthcare Strategies. For those of you not familiar with CHCS, our nonprofit organization is a policy design and implementation partner that works with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for children and adults served by Medicaid and related programs. Next slide, please. So this webinar is part of an initiative called Accelerating Child Health Transformation, which our team abbreviates to ACHT or ACT. And ACT is indeed something that we need to collectively do to ensure that all children and their families in the US have access to a healthcare system that serves their unique needs and supports opportunities for lifelong health and well-being. The current system fails too many children, especially Black, Indigenous, Latino, and other children of color. We need to expand the focus of pediatric care beyond medical care to also focus on more preventive and comprehensive care that fosters connections between children, families, communities, and the systems they interact with regularly. For this initiative, CHCS is humbled to be working alongside a broad array of partners and building on amazing past and present work done by others in the field. On our end, we are convening leading experts, pediatric providers, and family advisors across the nation to explore, identify, and share innovative ways to accelerate the transformation of child health care beyond medical care. And so through insights from subject matter experts, including ones with lived expertise, CHCS has identified 3 key strategies on this slide that are integral to child health transformation. And those are adopting anti-racist practices and policies to advance health equity, co-creating equitable partnerships between patients, families, and providers, and identifying family strengths and addressing health-related social needs to promote resilience. We're dropping in the chat a link to our synthesis report released last fall, which provides practical recommendations for providers, payers, and policymakers and others to consider adopting to transform child health care delivery along those 3 strategies. This report also identifies some accountability and financing levers that can help accelerate, support, and sustain improvements in pediatric care. Next slide, please. So for our agenda today, related to the intersection between these 3 strategies, our goal is to examine the impacts of conscious and unconscious provider bias, particularly as expressed through written and verbal communication. We're so excited to hear from a researcher, a parent and family advocate, and a pediatrician who are here with us today, who are going to share their research, experiences, and insights on the power of language in medical settings and its impact on health and health disparities. The presenters are also going to share strategies to improve language used in healthcare settings and to foster trust and dignity between patients, families, and care providers. And we look forward to hearing from you through your questions during the Q&A afterwards. Next slide, please. So I'm now going to turn it over to my CHS colleague, Hannah Gears, who's going to introduce our presenters. Hannah has been leading our race equity and family co-creation work for this initiative, and we are so grateful for her many contributions, which include developing today's webinar in partnership with the presenters. Thank you so much, Hannah.
Thanks so much, Armel. Good afternoon, everyone, and thank you so much for joining us today to hear from our 3 wonderful presenters. It's truly heartening to see how many of you all are interested in learning more about bias and racism and the ways that it shows up in the medical record. Before we dive into this topic, I just want to take a moment to think about what that high level of interest might mean. For some of you, this interest may come from a desire to better understand how your actions may affect others. Some of you may be interested in building your awareness on the topic, learning how you can influence the discontinuation of harm for people from marginalized groups. Others may be thinking in terms of the big picture. How can we reimagine a healthcare system where providers are not rushing from patient to patient in order to uphold the bottom line? Or could there ever be a healthcare system where racism and bias are simply not tolerated? For others, it may feel like a relief that the topic is finally getting the attention it deserves, but also you may feel the need to hold your breath until you see any action follow. We want to hold space for the way that each of you is showing up, and we hope to continue this important conversation beyond today's webinar. As Armel mentioned, we are incredibly lucky to have three presenters with three unique understandings and perspectives on today's topic: Nikki Montgomery, Mary Catherine Beach, and Ben Danielson. First, we will hear from Nikki Montgomery, who will provide some framing remarks. Nikki is a cherished member of the Family Advisory Team of the Accelerating Child Health Transformation Project. She currently serves as the Program Director for the ACL Healthcare Transformation Project at Family Voices, and Nikki's passion for empowering youth and families spans the last 2 decades, during which she has been an educator, a health literacy specialist, a patient advocate, and the parent of a child with complex health and educational needs. In addition to a graduate certificate in patient advocacy, where she focused on increasing the capacity of parents of medically fragile children, Nikki has done extensive research on critical thinking and health literacy for parents of children with disabilities. She's the author of the Super Safe Kids Pediatric Patient Education Series and currently serves on the editorial board for Pediatric Journal and the Global Patient and Family Advisory Board for the Barrel Institute, among many other health advocacy roles. So without further ado, I will pass it over to Nikki.
Thank you, Hannah. As Hannah said, I'm Nikki Montgomery, and I serve as a family advisor for Accelerating Child Health Transformation at CHCS. When Armel and Hannah initially asked if a family advisor wanted to present on the topic of racism and bias in medical records, I was immediately interested. I'm a former English teacher, 2 degrees in English, and I've spent a lot of years as a professional editor, so language is extremely important to me. And as a patient advocate, a patient and the parent of a child with complex medical needs, I've really seen firsthand the impact of language in the healthcare setting as either a tool to facilitate engagement or as a barrier that prevents engagement. So as we listen to Dr. Beach's research today, I really want to make sure we remain focused on the fact that provider documentation is not just about what's in the notes. There's a patient attached to each one of these encounters, and that's a patient whose experience in healthcare is reflected in those notes, and a patient whose trust might be altered because of that interaction. Anti-Black bias is not new, and it's not uncommon, and Black patients over the history of American healthcare have given their own accounts of poor treatment, of feeling judged, and of not being believed. Unfortunately, their experience often has been ignored, and it's been unaddressed. So none of what you see and hear today is going to be surprising, I think, to Black patients, but this research really validates the experiences and brings them forward for us to examine, understand, and change. So I hope that you are excited, as I am today, to hear from Dr. Beach, and I also look forward to presenting to you a little bit later about opportunities to build trust with patients, families, and providers.
Thanks so much, Nikki, for those important reminders. And it's so wonderful to hear the connection between this topic and your former life as an English teacher. Nothing that's shared on this webinar, as Nikki said, is revolutionary, and unfortunately, harm to Black and Brown patients is far too common. And so with Nikki's words in mind, we will now hear from Mary Catherine Beach, who is a professor of medicine with a joint appointment in the Center for Health Equity and the Berman Institute of Bioethics at Johns Hopkins University. Dr. Beach's research focuses on humanizing healthcare by promoting respect for patients, as well as improved patient and clinician communication. Much of her work has been aimed towards improving healthcare quality for patients who face systemic disadvantage. Dr. Beach has won numerous awards for her scholarship and mentorship, and we are incredibly lucky to hear her speak on her research today. I have no doubt that you all will find her work eye-opening. Dr. Beach.
Thank you so much. Okay, so I am going to talk about several different stages of work where we began to document how the language that's used in medical notes can adversely impact patients. So first, I'm going to talk about different types of stigmatizing language, so we have a really clear sense of what language we're talking about. Then I want to show you how we can look at the impact of that language on patient care and healthcare quality, look at whether the studies on racial bias in the use of that language, and then finally end with a few preliminary recommendations. So we've done several studies where we've looked at the ways in which doctors write about patients, and it is most common that negative attitudes towards patients come up in a very implicit way, rather than writing something explicitly negative. Physicians have become skilled at writing negative things in more subtle manner. So rather than describing someone as unpleasant, they might put details in the medical record that demonstrate why they think the person's unpleasant, and yet these details are medically completely unnecessary. So writing, quoting a patient in a way that might make that patient look like they're uneducated, using African American vernacular, in such a way that there's no added value at all to doing that in the record. There's also ways in which doctors indicate that they disapprove of the patient's behaviors. For example, she reports that if she were to fall, she would just, quote, lay there until someone found her, indicating that obviously the clinician did not think that was a good plan and was frustrated with the patient for not taking up the physician on the advice that they were making to have a medical alert. There's another whole theme around how clinicians undermine the credibility of the patient. And this is going to come up later in the talk, but saying things like he insists the pain is behind his knee, claims the nicotine patches don't work for him. Those are phrases that directly contradict what the patient is saying, and it begins to document just how much distrust clinicians have of the patient's stories. And in a further study around this theme of undermining credibility, this work that I'm describing really began in the realm of sickle cell disease, which is a condition that I have spent quite a bit of time working in. And there's direct statements in medical records of people with sickle cell disease to suggest that they're lying about the amount of pain that they have. And this, I think, is the primary cause for why people with sickle cell disease get their pain undertreated. So for example, it's not uncommon to have the clinician write that the patient has narcotic-seeking behavior when they're presenting with a vaso-occlusive crisis. But even more common is these indirect or implicit ways that clinicians express their doubt. So they will juxtapose the patient's report, which is supposed to be objective, with some discrediting clinician report, like the patient reports 10 out of 10 pain, but the labs are stable. Or they'll indicate that the patient's chatting or conversing lightheartedly to demonstrate that they don't actually think the person is having as much pain as the person is saying that they're having. Another way that they express doubt of people's pain is to use quotes to say that the pain medication is, quote, not enough, or the patient states, I am in as much pain as before. And then finally, as you saw earlier with the verbs claims, insists, reportedly, there are these signals that are directly discrediting to the patient. There's another theme that came up in sickle cell disease, which is a way that clinicians can place blame on patients. So in particular, that is often done when they highlight non-adherence in a way that suggests judgment. So not wearing mandatory oxygen, uncooperative, or using words like refuses. Those are ways in which we say this person is actually responsible for their whatever whatever bad thing is happening to them because they haven't been following advice. There are actually positive things that clinicians say as well about their patients. Clinicians do make direct compliments. You will say people are charming, pleasant, kind, delightful. They will make remarks that convey approval of the patient's or enjoyment of the patient. They will sometimes, when they document non-adherence, there's this whole category which we'll call minimizing blame. So they'll document the non-adherence, but they'll explain why. So that really humanizes and minimizes the blame that someone reading that might have about the patient. So she's not been checking her morning glucose because she lost her glucose monitor, or not taking iron because it makes her constipated. And then finally, there are personal details that the clinician might put in their note that would humanize the patient for the next clinician who's reading the note. So when you see something about someone that they enjoy walking with their fiance and their dog named Scout, that helps you relate to the person you're reading about as a person. Now, just going back to that stigmatizing language, one of the first studies we did was to try to document whether if you put this language in the medical record, we always thought it was like a reflection of bias, but the question was for us then, does it propagate bias? Like if somebody else reads that language, are they going to have bias against that patient because the language is there? Which might seem like an obvious question. I mean, I think it kind of is, and yet somehow we need studies to demonstrate this so that we can, convince people that this is important. So this was a study we did where we created vignettes of where we used stigmatizing language, and then we rewrote the vignette with neutral language. So these are hypothetical patients, and we were able to then randomize clinicians to read one of the two vignettes and see whether, if they read the vignette with the stigmatizing language, did they have more negative attitudes towards the patient, or were they less likely, were they going to give lower doses of pain medication as a result of that language? And so we used examples of stigmatizing language that we had found in actual medical records. So, for example, a nursing note said, he is insisting that his pain is, quote, still a 10. His girlfriend is lying on the bed with her shoes on and requests a bus token to go home. And so we wrote it and said, he still has pain rated 10 out of 10. His girlfriend is by his side, but will need to go home soon, because the other details are frankly irrelevant. And what we found was not surprising. There's an attitude scale that we had developed so that higher numbers mean more positive attitudes, and the numbers themselves don't exactly really mean anything. It's just to show you the magnitude of the difference. But in the neutral language case, the mean attitude score, positive attitude score, was a 25, whereas in the stigmatizing language case, the mean attitude score was a 20. So, 5 points, it's a hypothetical scale. The point is that there was an impact and it was statistically significant, so that stigmatizing language led to more negative attitudes. Similarly, with pain management, the higher the score on this scale means that the clinicians prescribed higher doses of pain medication. And so in this case, if you were in the neutral language condition, you prescribed your pain management was at a level of 5.3, whereas the stigmatizing, it was significantly less at 4.7. So you can see then that if you put the stigmatizing language in the record, the people reading it are going to be less aggressive in the pain management that they deliver to the patient. Now, we also then took the next step, as have several other people. I'm going to show you a couple of studies here to try to see, is there a systematic pattern demonstrating racial bias in the use of stigmatizing language? And the first study I'm going to show you is not one of ours. This was a study published quite recently in the journal Health Affairs, and it was called Negative Patient Descriptors. And in the top right of the slide, you can see the various terms that these authors searched for in the medical records at a large academic medical center. There were terms like adherent or non-adherent, aggressive, agitative, angry, challenging, etc. And they looked to see whether there were differences by race and by gender. And they found significant differences in those languages, so that there were, if you were a Black patient, you had a 2.5-fold odds, so 2.5 times more odds of having one of those descriptors in your medical record compared to a white patient. And if you're Hispanic or Latino, you had about 1.5 times the odds, so about 50% more likely to have one of those descriptors in your record. Following up on this issue of whether Black patients are more likely to be disbelieved, there's a quote in the Chicago Tribune from an article that was called 9 times out of 10, I was completely brushed off. And he says, if there was ever a book on medical racism, it should probably just be called They Don't Believe Us. And along those lines, in previous work that I've done, when I have interviewed people about the term, like what it means to be treated with respect, it was striking that in our African-American focus groups, people described being treated with respect as being believed and taken seriously. So, you know, what that 9 times out of 10, I was completely brushed off. These quotes are also from people who have had that same experience. So, you know your body, when you come in a position of being controlled, you know yourself, or you cannot tell me there was nothing wrong. And that came up over and over again. And if you think about what we're seeing in medical records, where clinicians are expressing that they don't believe what patients are saying, and you match that up against what African-American patients have been saying for a long time, you can see that there may be a way to document objectively that people's experiences are discoverable by looking in the medical record. And so we did a study where we looked at various markers of doubt, you know, drawing on that work that I had shown in the beginning of the talk, whether there were judgment words like insists, claims, apparently, reportedly, adamant, those kinds of words, or whether there were quotes used in medical records. And we found that there were significant differences by race in the use of all markers of doubt. So for example, in the medical records of Black patients, there were 29% had a judgment word compared to 21% of white patients. And that was about a 25% increased odds of having one of those words used in your medical record. And the similar finding was had with looking for quotes. So I just want to summarize and make some reflections and recommendations. First, I think we've shown that languages in the medical record can convey people's biases, that it perpetuates stigma that influences subsequent providers who care for the patient, that it may reflect or perpetuate testimonial injustice, especially for African-American patients, which is something I think we need to pay a lot more attention to and hasn't gotten enough attention. And I also want to point out that now that patients have access to their notes, there was a study that found that 1 in 10 people who were able to look at their notes found something that they were offended by or they felt judged. And this study, linked here in this slide, shows all the different ways that patients can be offended. And a whole big category of that is just disrespect. So not being heard or being misquoted, having someone be condescending. And those are things that I showed you in the beginning. Like, we can see these things in medical records, and obviously so can patients. And so when I talk to a group of clinicians, I make a couple of recommendations, and I'm sure many of you have some other recommendations, but a couple of them are to avoid expressing frustration with patients. Like, don't include, if you're personally frustrated by somebody, you have to check yourself and take a deep breath and step away from it and realize that's you. Stay aware of your own emotions and don't put that language in the medical record. Strive for testimonial justice. And by that, I mean, second guess whether what you think someone's telling you, if you think somebody's telling you something untrue, or that they can't remember, they're just not, even if they're not lying, if you think that they're just not telling like the right story because they don't remember, check your assumptions on that. And when you're documenting something in a medical record, don't use words like claims and insists where we directly contradict what somebody has told us. When somebody is non-adherent, try to express why. Try to think about what's going on in that person's life. Don't label people as non-adherent and make it a personal responsibility issue. Just try to think more broadly about the patient and think about ways in which you can minimize the personal blame for someone who's not able to or is not interested in following the advice that you think that they should follow. And then I think just really be very careful with quotes. Quotes have become a convention in medical documentation. People do it all the time. I think that there are many negative ways in which quotes can be used. And I think clinicians should very rarely use quotes. And when they use them, just be very careful. So I just want to end there. Thank you. I look forward to hearing the other speakers and then hearing your comments and your questions.
Thank you so much, Dr. Beach, for sharing your report and all of your research in such a digestible way. I have a feeling that a lot of folks are going to have questions about your work, and I certainly encourage those of you who are interested to spend some time reading Dr. Beach's reports, which we can link to in the chat as well. So as a reminder, if you have questions, please put them in the chat, in the Q&A function at the bottom of your Zoom screen. And now I will turn it back over to Nikki Montgomery for her presentation on opportunities to build trust between patients, families, and providers.
Thank you, Hannah. Thank you all. And again, I come to you as a patient and the parent of a child with complex medical needs, as well as a patient and family advisor. And Dr. Beach's research is very meaningful to me, not because I'm shocked or surprised by the findings, but because the findings really do validate what Black patients have been saying, both historically in healthcare and in the present. Since the beginning of the pandemic, I've heard so many different conversations about trust among Black patients, and you probably have too. Some of those conversations centered around the effects of the Tuskegee experiments and medical harm that Black patients have had over history. Some of them have focused on medical exploitation, a la James Sims and Henrietta Lacks from the medical community. And also there have been a lot of conversations around trust dealing with vaccine uptake in the Black community. Black patients are generally known to be less likely to trust institutions, including healthcare. But what we've seen today, I think these are examples of the moments, the personal interactions that get abbreviated into clinical conclusions that really reproduce and reinforce the distrust Black patients often feel. So each of those notes that we heard about is connected to a patient whose needs were minimized, whose culture or speech was mocked, and whose treatment was changed because of a judgment or a bias. Those notes give us a glimpse into the power dynamic in healthcare, and there's absolutely no way that the patients in these encounters were unaffected by the bias that shows up in the notes. The concept of epistemic injustice is thought-provoking to me because I reflect on who has the power to tell a story and who's believed, whose knowledge gets overlooked. So the effects on patients might not even be known or felt in those moments, but we do know bias affects treatment. And we know anti-Black bias is as common in healthcare as it is anywhere else in society. We also know that Black patients often seek Black providers to avoid that same kind of bias and discriminatory treatment. So I'd like to dig a little deeper. Next slide, please. As we mentioned, before we really get into the heart of this, I do want to focus on this quote for just a moment. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane, and that's by Dr. Martin Luther King. Next slide, please. So we did mention before that I used to be an English teacher, so I do like to clarify definitions to make sure that we have a common concept of something. And I want to just talk about these definitions here. So trust is a noun. It's the belief that someone or something is good, reliable, honest, effective. Mistrust is a verb that means to doubt the truth, validity, or effectiveness. And then distrust is the absolute absence of trust or the lack of trust. And I've been having so many conversations about trust in healthcare, and I have to admit that I've found them distressing very often. I feel like a lot of emotions are brought up with conversations about trust, especially for Black patients. And as we sit with these definitions a little longer, I do want to tell you about a story from my own patient experience that shows where trust, mistrust, and distrust kind of come together. So about 4 or 5 years ago, I was having my general physical with my primary care doctor, and she had looked through my charts and was curious about my occupation, which at the time was a professional editor. And through casual conversation, she just kind of asked me about my education, about my involvement in healthcare, which came up as I talked about my son and my life. So we kind of were having a decent conversation about my involvement overall. Now she's still doing my physical exam, and as she gets around to my back and sticks the stethoscope on my back, I had to move my hair out of the way. And she pauses for a moment and she says, "Can I ask you a question about your hair?" And as a Black woman, a little yellow alarm or a little caution alarms going off in my head, because I know conversations about hair are cultural conversations that can really mean a little bit of trouble. So I said, "Okay, you can ask me a question." And she said, "Well, how do you wash it?" So here, the little yellow light is turning red, and I say, "Well, I, use shampoo and water and work it up into a lather and rinse and repeat." That's a little response I got from Alice Walker. And the doctor did not pause there, and she just said, "Okay." And she says, "Well, I have this other patient with hair like yours." And that, of course, caused me to pause a little bit more. And she says, "That patient's hair was so dirty and disgusting. It was dusty. And she came to me asking me to change her prescription for her allergy meds. But her hair was probably the reason she was having trouble with her allergies." So naturally, at this point in the conversation, all the alarms are going off. The doctor continued, "I was not going to give her any more allergy meds because really all she needed to do was wash that hair." So as a patient, I'm sitting in this interaction pretty stunned into silence, didn't really know what I wanted to say next, but I said, "Well, I'm not sure what her situation was," and just kind of let the conversation trail off. But I left that appointment with that experience really echoing in my mind. And where I see these 3 concepts coming together in this story, and we can go to the next slide next. First, there was trust here, right? The silver lining was that the doctor did trust me enough to ask me about my expertise on a topic. Now, that asking me actually showed up in the middle of a doctor's appointment that she had hijacked to ask me about some cultural training about Black hair. So it wasn't the best format, but she did have a trust in me that allowed her to ask that question. However, it was apparent that the doctor really did not have trust. She showed mistrust for the other patient. She didn't trust that patient's symptoms or her accounts of them. The patient was stigmatized as well. And then finally, what I get out of this encounter is that it changed my trust. So it caused distrust for me in that provider. I recognized that she showed bias to the other patient. I recognized that she altered her treatment plan because of that bias. And I was not able to trust that provider anymore. So I decided not to go back to that provider. I actually changed providers, which delayed my own health care. So it had a ripple effect. But that story to me shows how all of these topics can converge together. And over time, I've reflected on this a lot more, and I've thought a lot more about that other patient. I was believed, she was not. I have no idea what was written in the notes about her healthcare encounter, but she was not heard. Her experience was not trusted. And I've thought a lot about what her experience was following this healthcare encounter. Next slide, please. So a lot of what I thought about is what makes you believable. When I reflect on that story, I think about my own credibility and what characteristics made me believable and her unbelievable. So when I enter the healthcare system, I enter with certain layers of privilege. I have communication skills. I have education, socioeconomic status that might be more on par with what my physicians have. I have knowledge of healthcare. And not only do I have knowledge of healthcare, but I've actually participated in improving healthcare. And all of those different layers of privilege change my experience. But what I reflect on is what happens if those are stripped away. This story is really a glaring example to me of what happens to patients who don't. have these various layers of experience. So if we take away my participation, we take away my knowledge, we take away my education and socioeconomic status and communication skills, then you just have me there. And am I believable without all of that? Next slide, please. So one of the things I like to think about here is what the direction of trust is. We've had all these conversations in healthcare about improving trust among Black patients for healthcare, but we never really approach how we improve.
Oh gosh, I'm so sorry. It looks like Nikki's screen has frozen right in the middle of such an incredibly powerful presentation. I wonder if we can give her just a minute to see if she can log back in. So I will ask you all for your patience for just a second, and we'll see if she can log back in. And if not, we will continue on to our next presenter. So thanks for your patience. Hi, Nikki. It looks like you're back.
Awesome. Sorry, I had to change devices, but we'll keep the show going.
No problem. Thank you so much for your flexibility.
Okay, thank you. So I'm going to assume you didn't catch the last part, but I did want to add that quote there, tell me who I have to be to get some reciprocity. And here I want us to focus on the fact that trust has to be reciprocal, but often it seems to require some level of change on the part of Black patients versus their providers to improve that trust. Next slide, please. So this is where I want to talk a little bit about who I have to be to get reciprocity. When I talk to Black patients and families, a lot of times as they prepare for healthcare encounters, they are preparing by making changes to who they are. They may change the way they speak. They may sit up and look like they're paying attention and give better eye contact. They may be extra charming and charismatic, or feel like they have to over prepare for every healthcare encounter. And for those who do have the privilege of education and career, they may even add those details into healthcare encounters. And it does sound like these might be positive things, right? Of course, we want people to be attentive. Of course, we want them to be charismatic and prepared for their healthcare encounters. But the question here is why they need to do that. And for Black families and Black patients and caregivers, those adaptations are often because they need to humanize themselves. They're often because they need to do this for safety. So yes, engagement is fantastic, but knowing that you have to engage in certain ways in order to get safe and adequate treatment is a whole different dynamic in terms of power. Some of those intended outcomes that families have when they do this performance is that they want to be humanized, they want to be seen as equal, they want to be seen as capable of managing care, and they also want to be seen as credible, all in hopes of actually getting their needs met. And as we saw in Dr. Beach's research, some of those needs are not met when they're not seen as credible. So if the performance is because of a fear of harm, that's where the disparity and the trouble come in. Next slide, please. So as we talk about what Black patients know and honoring other types of knowledge, I think it's really important to realize that Black patients do know about personal experiences of anti-Black bias in society. They know about the history of poor treatment and outcomes in healthcare. And often in a very localized way, they know about which institutions in their own communities have a history of treating Black patients poorly. Early in my marriage with my husband, we moved around quite frequently. And we would always, when we moved to a new town, say, hey, which hospital should Black patients not go to? And there was a remarkable amount of consistency in every community about which places were going to provide the worst care for them. So there is that oral history of what poor treatment looks like, not just much more globally, but also on a local level. And Black patients also realize they're vulnerable to the biases and beliefs of other people and to not being seen by their providers. So when we talk about building trust with Black families and Black patients, we have to realize what they already know and the knowledge they bring in. And I have this quote on the slide that's often attributed to James Baldwin, but I found that it actually originated with Ike and Tina Turner. But it's, I can't believe what you say because I see what you do. So I think it's important to realize that there is no domain in healthcare in which Black patients are the comparison group for excellent outcomes. And we know that. So we have to recognize the knowledge that Black patients bring into the healthcare setting. And when we're talking about building trust, it's a little, it's not entirely harmonious to ask them to trust you when we know about these experiences here. Next slide, please. So what I want to talk about here is what do we do about all this? And I really would like providers to think about what their default setting is on trust. The labor of being believed and believable has generally fallen to Black patients, and it cannot just be our burden to do. I think it's important for providers to examine those impulses to disbelieve patients, to think about where they're coming from, not to judge your patients based on their levels of privilege, to do the work of examining your own biases, not just in a training session, but also in real life experiences and reflecting on them afterward. Providers should not be questioning the credibility of their patients' accounts of their own experience. You know, we should be considered experts on our experience, on our pain levels, on how we feel in our own bodies. And then realizing that Black patients can't just be expected to trust you, especially if you do not trust them. So many of the outcomes Black patients experience really are not about our trust, but are about the trust of our providers. Next slide, please. So where I want to land here is about building trust, right? But not about building my trust. As providers, I want you to think about building your trust. Harm is happening to Black patients, right? We know this. We know that they're experiencing bias and differential care. It is illogical to believe that that harm is happening and no one has to be responsible for it, right? There's no culpability for that kind of bias in healthcare right now because we're not measuring for that. But as you are looking to build your trust in patients, you need to understand the privilege they bring. You need to communicate clearly and make sure that they are able to participate equitably in their own care, and also demonstrate the trust you want to experience. So that means asking patients and having two-way conversations about their concerns and actually listening to their concerns and answers. We have to be able to prompt these two-way discussions that actually build relationships. So knowing that healthcare is doing harm to Black patients in the moment and asking them to actually trust that healthcare will not harm them is abusive. But a different solution is to trust Black patients, period. Understand that patients are coming to you with varying levels of privilege and influence, and then those differences are what you need to use to communicate effectively with them. If you want to build trust with Black patients, trust Black patients. So a couple of years ago, my son had an appointment with one of his providers. And after the visit, I went to his EMR just to read the visit notes, as I usually do. And the first sentence read, Richie, a race car enthusiast and future astrophysicist, came in with his mom for a follow-up visit. That first sentence let me know that she had seen him, heard him, and established a relationship with him. And then later in the notes, she actually cited a concern that he had brought to her about his own health status. along with the plan that we had all come up with together to address that concern. So she showed me again that she was listening to him. She believed what he said about his experience in his own body. And she trusted that the three of us together could come up with a solution that worked for him. That to me is the foundation on which trust can be built. It shows the relationship. It shows the positive regard. And shout out to Dr. Chris Hardesty for that encounter. But I want to leave you with the fact that building your trust is essential to these relationships, not just building the trust of Black patients. Thank you for your time and patience with my technical difficulties today.
Thank you so much, Nikki, and thank you for your grace under unfortunate circumstances, but thank you for coming back on so quickly. And thank you so much for your presentation. I know we are all walking away with much more clarity around the true meaning of trust within the medical construct. And thank you for sharing your own story around your personal experience with your provider. I know I personally was filled with frustration and rage as you shared that story, but of course, this is not unusual at all for Black women and Black and Brown people. And we, particularly white people, have a responsibility for ensuring that this doesn't continue. Your recommendations to providers were wonderful on top of Mary Catherine's. They certainly hit home. There's no such thing as a one and done training opportunity, and there is a lot of unlearning to be done. So thank you so much, Nikki. Now we will turn and hear from Dr. Ben Danielson, who is a pediatrician that has been dedicated to providing equitable care to all children and families throughout his career. He's well known for his 2 decades of service at the Odessa Brown Children's Clinic in Seattle, where he worked to uphold the clinic's enduring tradition of growing wellness through quality care with dignity, community engagement, and honoring of culture. Dr. Danielson has served for many years as a clinical professor at the Department of Pediatrics at the University of Washington School of Medicine, and he recently joined a pediatric practice with the University of Washington Medical System. Dr. Danielson also serves as one of 4 members of our core faculty for the Accelerating Child Health Transformation Project and has provided our internal CHCS team and each of our learning community sites with foundational knowledge of racial equity and continuous guidance. Dr. Danielson.
Thanks very much for the opportunity to join this conversation today. I will just admit at the beginning that I'm the lesser of these 3 conversants in so many ways. The expertise that you heard, the experiential lived and living expertise that Nikki shared, and the research expertise that Mary Catherine provided were just really remarkable. Nikki, man, you have to be tapping into so many old feelings, right? Old experiences of being a Black child, and the storyline was that you had to put on your Sunday clothes because you're going to the doctor today. How you had to really prepare, and how many times that old piece about twice as good was especially important when your health was at risk, because as a Black person, you knew you were entering into a space that was potentially harmful to your health even as you sought healthcare. I so appreciate the honesty and the vulnerability and the just the straightforwardness with which all of that was shared, and in the background of the knowledge that was coming from the research down in the previous presentation. It's been interesting to me to listen as well and hear the way we've been shifting back and forth in this trust conversation between the idea of providers trusting patients and patients trusting providers. And it's so important to do what I think happened, which is really be clear about which dynamic of trust we're talking about there, because there are significantly and gravely different both power hierarchies and other components of those dynamics that must be taken into account, that there's not equipoise and equal balance of issues when you're talking about the trust that a provider should have in a patient and the trust that a patient may not have in a provider. It's interesting to me also to have this conversation in this time, and I just want to name something that may or may not bleed into people's thinking, but we've been going through a lot of dialogue in this country right now around the idea of misinformation, and how misinformation may be weaponized to undermine different, say, public health practices, different kinds of measures necessary for our safe and health. And I really want to make sure that we do not overlap or confuse what is an issue in this country of misinformation from this conversation, which is completely and uniquely different about trust in my mind. It's an interesting thing to think about trust, and it's sort of language base that was so eloquently explained by Nikki, and its dynamism as well. That trust is really a dynamic and living entity that's steeped in a pretty deep history and carries that history through generations and through experiences that are near but not directly the experiences of individuals, that communities feel experiences of trust, that histories and generations feel experiences of trust or distrust. And it's also really, really important, I think, to double down on the emphasis that Nikki was making about the wisdom of distrust. That for patients who distrust healthcare, for Black and Brown patients particularly who distrust healthcare, that is actually an incredibly smart perspective. That is not a flawed perspective. It is not a deficit from which we need to sort of speak from or go from. But it's important for me as a pediatrician, it's important for me as a Black man to really state that a patient distrusting the healthcare system based on the legacy of racism that's built into it is a smart position to be in. So it is wisdom that drives a Black patient, say, distrusting healthcare, and which is really different than the different positions that providers may or may not have in trusting patients. This idea of trust is also interesting to me, and I will not pretend to be a language expert, so Nikki's going to have to come back and correct everything I said. But I've come to believe also that that there is something slightly imperial about the way healthcare people talk about trust, and how there is this expectation of trust that they carry, that we carry because of our hierarchy, because of our positionality in society. There's this almost presumption that there should be trust towards us in healthcare, and I think that is so problematic. It creates this dynamic where healthcare people can think that they are unilaterally and unerringly endowed with trust, should be presumed to have trust, and that is so truly presumptive. It's made me rethink this word trust, and I think I want to encourage us in healthcare to not talk about what we need to do to be trusted, because I still believe that especially for BIPOC, Black and Brown families and patients, it is up to them to decide when and how much and whether to trust healthcare. So we can't name their trust. What I think we can do is name what we can be doing to be trustworthy. So I prefer inserting this word trustworthiness into the actions that healthcare needs to do in order to earn, to justify, to even hope for the beginnings of some layers of trust. But I don't think we get to say, if we do this, then we deserve to be trusted. Because that, again, presumes something that is really the ownership of patients and families to name or not name. So let's think about the things we can do to be trustworthy, not the things that we can do to be trusted. I really appreciate also the comments by Mary Catherine when she was talking about respect, because I do believe that many of the issues that that really harm the way healthcare is delivered in this country, especially as it relates to Black and Brown families, is around a lack of promoting dignity. And that the practice of promoting dignity is so built into this conversation that we're having now, that the idea of really being especially conscious of the need as part of your healthcare practice to promote dignity has to be a piece that comes into all of our practices, I think particularly in pediatrics, but across the healthcare delivery spectrum. The idea that dignity is an inherent part of trust and trustworthiness is something that we have to start talking more deeply about, because dignity is undermined because of the language that ends up showing up in charts in those studies, and by the way that someone experiences healthcare beyond that. So it is also important for us to contextualize this misuse of language in, say, health records is also part of an environment that is harmful to Black and Brown families, that families entering healthcare experience a whole multi-sensory experience that is harmful. That language that is written into their charts that may or may not be seen by them. It's also the sense of surveillance, the sense of being sort of hyper scrutinized and yet still unseen, the sense of being hyper judged for anything that ranged from not enough emotion to too much emotion, from not enough conversation and discussion and explanation to too much conversation, discussion, and explanation. That we have to make sure that we contextualize all of this conversation about the language of trust, and also the environment of trustworthiness that healthcare does not seem yet to be able to convey or provide. I'm reminded of this story that a mentor of mine was sharing with me from the Indigenous community of a expecting mother, an Indigenous woman who went into a hospital to deliver her baby, and how the staff became very concerned because this woman was extremely stoic, was not expressing anything, and was not sharing her, anything about her ideas about parenting or wanting to be a mother. And so the medical record started to show mentions of an emotionally unattached parent, potentially, and concerns that this person is not engaged in motherhood, is not ready to be a mother. If you can believe it, that was the conversation that the healthcare staff was starting to have, enough so that they actually ended up reaching the ears of folks in the Indigenous healthcare community. And luckily, a Native physician, an Indigenous physician, came and visited this mom in the hospital, and suddenly she exploded with language, was extremely expressive, was so excited about being a parent, so invested in, and deeply curious, and also just feeling wonderful about the idea of parenting, and that whole misconception that was turning into language due to the lack of exchange that was really rooted in a woman who has very good reasons not to trust a healthcare system, and then having anyway to walk into that space and do something extremely, extremely scary, which is have a child when the healthcare system that she was entering was really of dire threat to her. These experiences, these ways in which we as Black people, so many others as Black and Brown and other BIPOC folks, have to prepare themselves to enter spaces that are full of adversity. I know that's not something that other folks have to even think about, even have to think twice about. You know that you are going to be centered when you walk into spaces like that. Whereas for us, that's just not the experience that we have. This whole story that Nikki was sharing, and the need to be twice as good in order to get anywhere near the same kind of care, is so painful and is so exhausting and so difficult. We have to hold ourselves as healthcare professionals to a different behavior and a different standard. We have to be working to be trustworthy because we cannot expect trust without major changes in the way we do things. This is an important opportunity in this conversation, I think, to unroof some of the things that people want to say are very subtle about issues of racism, hard to tease apart and hard to recognize. And I so appreciate the bright lens that Mary Catherine has brought to this to allow us to actually see this, and the warm light that Nikki has brought to this to actually help us feel this. Both seeing this and feeling this has to be a prompt for us as healthcare professionals to care deeply about doing things differently. I am not here to talk about the issues of healthcare providers trusting patients, because I think it is abhorrent that that is something that we even need to enter into in this particular forum. But I am talking about what healthcare providers need to do to be trustworthy to patients who are very deserving but have had a history over time of being misused and harmed by the healthcare system. I hope that you look at other words and that other people use in charts differently. I hope that you look at whether or not language that you see is something that you feel should be perpetuated. Or I hope that we create opportunities for countering messages that may have been placed into those charts that somehow become, oh, they just permeate and they project forward and they reverberate, sometimes repeated by other providers in future charts as well. I hope we think about questioning, as Nikki said, why particular language was used, what somebody was bringing into it to say that, but just period. Why was that language used? What was happening in the mind of the provider when that language was put? And I hope we also start to think about where else our language is misused, where we run away in our conversations with other providers from the appropriate language about racism, where we move away from an ability to really understand where our biases show up and try to use alternative language instead, even in our conversations with each other about this important topic of equity and anti-racism. This is an important conversation. I look forward to the dialogue that comes on after this, and I so appreciate the chance to listen and learn and be part of this along with Nikki and with Mary Catherine. Thank you very much.
Thanks so much, Dr. Danielson, for sharing your wisdom with us today and also for your affirmations to the other presenters. We so appreciate your candid presentation as always, and what a great reminder of what really counts in healthcare. And also your reframe of trust and trustworthiness. I think that was really powerful. But without taking up more time, I did want to jump into the Q&A portion of our presentation because we already have quite a few questions. So if you have not yet put your question in the question and answer box at the bottom of your Zoom, please do. But otherwise, I will go ahead and ask the panelists to join me on camera, and I will go ahead and start asking some of the questions from the audience. I first wanted to start by acknowledging the many comments that were submitted that referenced a deep appreciation for you, Nikki. There are so many comments saying how valuable your presentation was. And so I think there is a huge appetite for vulnerability and directness that we don't usually expect when we jump on a webinar. So thank you. The next question is a much more practical thing for you, Dr. Beach. Folks are wondering, are there any existing resources that could assist providers in understanding the power and detriment of documentation? Do you have any recommendations?
No, I don't know of anybody that has paid attention to this. I think that there are, in terms of documenting in medical records, there are language guides around treating diabetes. The American Diabetes Association and the NHS have come up with, in collaboration with people who have diabetes, have come up with ways of talking about diabetes that are stigmatizing to people with diabetes. The AMA has come out with a language, suggested language guide that I have seen and is very good. It's not specific to documenting in medical records. I think the things that I showed about medical record documentation are not things that people have paid attention to until very recently. We did just I saw there were questions also about the use of quotes and how clinicians are taught to use quotes. And we did just write a practical paper in the Annals of Internal Medicine on when and how to use quotes. And it addresses that, the benefits of quotes. Like, there could be a benefit. And we talk about when we think it might be beneficial, when we think it's harmful, and how they can be misused. So there's a little bit of guidance on that we put out. It was just our opinion, but I do think that, we should be creating those kinds of resources now.
Thanks, Mary Catherine. I think that definitely just shows the gap in attention that there has been thus far, but also an opportunity. So thank you. There were also a few questions that simply ask, do patients have better outcomes when their physician is Black? And does the race and ethnicity of the clinician or provider change how susceptible the person was to stigmatizing language influencing their care, and also how they write about BIPOC patients in their own records? So I think that's another question for you, Mary Catherine, but also something that Nikki, you spoke to a lot in your presentation. So feel free to unmute and speak to that as well.
Yes, outcomes are better for Black patients who have Black physicians. There have been many studies that have shown that. We weren't able to look at the characteristics of the clinicians that were associated with more or less respectful documentation, because we don't have those details about the clinician, or we didn't have them in the medical record. So we weren't able to kind of link to that. So we weren't able to look at that. I suspect, just like most studies have shown that outcomes are better for Black patients with Black physicians, that the language is less stigmatizing.
Thanks, Mary Catherine. Ben, did you want to add something as well?
I turn these into conversations sometimes, so apologies. But Nikki, I mean, the way you described what was a truly robust understanding of your son in a healthcare experience, that's a different conversation, isn't it? That's just a completely different body of information and sharing of that information, and that's so noticeably qualitatively different. And let's stay on track and remember that this is about the language of care, but what we ultimately care about is the care itself as well. So the question in there could make somebody want to just emulate the way a Black provider might write about a Black patient. And there's just so many traps that could be kind of built into that, because then you're performing. And that's a little bit different than actually fully building trustworthiness.
And I would add here that it's often a safety issue that makes Black patients seek Black providers. That's not a stressor that you're going to have to deal with. So just not wanting to encounter bias and discrimination is enough to send people away. But even the route of trying to find the right provider that you can trust can be full of pitfalls. And when that trust is broken, then you have to start all over again, or decide to live in a trustless relationship. So that whole path of continuity of care is affected by this too.
Absolutely. Thank you, Nikki and Ben. And Ben, thanks for turning it into a conversation. I think that's much better than the classic Q&A. The next question is also for Mary Catherine. What is being done to address the minimization of pain in girls and women, especially girls and women of color? How can we move forward with advocating that the pain we experience is real and we aren't just, quote, strong and brave?
Yeah, I mean, I don't know if I'm the best person to answer that question. I could talk a lot about pain and sickle cell disease. And I'm an adult physician. So maybe I'll turn it to my co-panelists and then see if I have anything to add after they've responded.
I have a feeling that the two of you can respond from your heart and maybe not from a research mind, but I will defer to you.
My heart says trust your patient. No one decides to haul themselves into the healthcare environment for fun. We don't expect this to be an enjoyable experience. This is not something that people are doing because they want to waste your time or their own. So essentially, I don't know what work is being done, but the work on the provider end is just trust the patient account. There may be instances where you're wrong in that trust, but there will be many more instances where that will build trust and build a better relationship.
The need to be very intentional and clear about believing is the words are painful coming out of my mouth because this is not the kind of conversation you should have in a humanistic society and in a caring profession. But the need to actually be intentional and learning about leading with believing is a really important piece. We have had diverting dialogues about things like substance use disorder and its roots in prescribing practices. And I would not be surprised if a few people listening are having some little thing in their mind about that diversion of a topic. There are other ways in which we have not been leading with belief in our work. I was presenting an ethics class to some medical students a couple of years ago now, and set a patient scenario that was a sickle cell patient scenario, just as Mary Catherine spoke of, and left it open in terms of whether or not the medical students were going to believe that this young man, in this case, was in pain. And a medical student said, "Well, I guess we need to do some pain tests to see if he responds adequately to painful stimuli." What I heard there was a medical student saying we need to torture a patient in order to determine whether or not they're believable or not. That's chilling to me. It's incredibly painful, and it tells me that we cannot just rely on good intentions in this work necessarily. We actually have to be intentional about making sure that we are leading with belief and believing in our patients. Sorry for that rant.
And on the topic of pain, I'll add that there is still a lot of ignorance about biological differences in pain tolerance between Black and white patients. So there's that clouding this scenario too.
I mean, I'll just say that part of why I get thrown off by the question is sort of what is being done to fix this. And, you know, I think there's so much to be done that isn't being done right now that, you know, but, you know, I started in sickle cell disease because people with sickle cell disease seem to get treated so poorly, so much more poorly than anybody else for so many layers of bias. And, you know, it strikes me that I don't think we've made, you know, even not even hardly any progress since I started doing the work. So I think I've been a little frustrated by that, and it's hard to say, you know, what's going on to address it. I feel like just not enough.
Well, thank you all. Unfortunately, our time has come to a close, but thank you so much to the presenters. Thank you to the panel or to the participants who submitted so many wonderful questions, and to the Robert Wood Johnson Foundation, who supports the Accelerating Child Health Transformation Project. And I do want to note that because we have so many wonderful questions, we will hopefully pull together a communications product to ask the most common questions, just because it sounds like there's an appetite for more. So thank you all so much. And we look forward to continuing the conversation. Have a wonderful day.